Hi, this is Brian Kim. I'm going to share with you case number 239 in the Best Way to Do Cataract Surgery series. And the title of this series is not to suggest this is the best way, but to get you to think about your technique, be critical of your technique, and consider honing and refining your technique so that you can do the very best for your patient. And so that's the whole purpose of why I post these videos. And as you can see, I'm always trying to grow and learn from each of my cases. And so you're going to see this case, this patient has a really small pupil, which actually shrinks throughout the case. And this patient clearly has IFIS, intraoperative floppy iris syndrome. And you're going to see that very early on in the case and how I navigate around that very floppy iris. And there's some critical components to how I manage this floppy iris. And the first thing is to never apply vacuum when I'm chopping. Because I do the double chop and cross chop, which doesn't require any vacuum, I'm able to just position the instruments around the lens. This gives me exquisite control, and I never have to worry about accidentally eating the iris. And so my risk of grabbing the iris is very low. But then also I'm going to use the chopper to shield the pupil from the phaco tip. Because remember, the phaco tip has vacuum, and I have to use vacuum to get the pieces out. But I also want to shield the iris. And what instrument can I use? Of course, I have the chopper. So I use a corneal marker, which will help me to center and size the rexus. And then I make my paracentesis incision, first on the right side and then the left side, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral epinephrine. As I'm irrigating the eye with the epinephrine, you're going to see this tiny little pupillary strand. And I highlight this strand simply to say it's going to show up again later on in the case. And so I'm irrigating the epinephrine inside the anterior chamber and trying to expose that iris to that epinephrine, hopefully to stabilize the iris. And this is some dispersive viscoelastic, and you can see there's quite a bit of viscodilation in this pupil. Again, it hasn't shown to be IFIS at this point. It just seems like it's a small pupil, but again, not an IFIS case quite yet, but you'll see soon enough why it is an IFIS case. So I puncture the center with my microforceps. I grab the right side of the tear, but as I do that, you see that I got snagged on that pupillary fiber, that little fiber that was on the edge of the iris, and it snagged on there. But as I'm going around, and you can see there's OVD egress from the wound, you can see the IFIS occurring. You can see the iris is trying to prolapse out of the incision. You might ask yourself, was the keratome incision shallow? Do I not have enough of a shelf? But I went back and looked at the case, and I have a really good shelf. So this is not an issue of a poorly constructed wound. This is purely just an IFIS case. You saw it throughout the rexus. I was very careful to burp the wound little by little and making sure I had excellent control to prevent any more iris prolapse. And this is the capsule fornix hydrodissection. This is very important. As I'm pushing the BSS fluid to cause hydrodissection, I'm acutely aware that that's going to increase the intraocular pressure, therefore it's going to cause the pupil to try to come out. And so as I'm doing the hydrodissection, I'm looking at the iris, I stop, I decompress the eye, and then do some more hydrodissection, stop again. And so I'm very aware when I'm doing hydrodissection, I'm increasing the volume inside the eye, therefore you're going to increase intraocular pressure, and so you have to release that pressure valve, but do it very carefully because you don't want sudden iris prolapse. So I'm just very ginger when I'm doing the hydrodissection, and then you saw at the very end, the lens began to spin. Lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma. I slide the chopper under the rexus edge, leading off with the tip, pushing down on the lens. I'm making sure I go under the rexus edge, and then I turn vertically, making sure I'm around the lens equator. So now the chopper is at the lens equator contra-incisionally. I turn the phaco tip vertically sub-incisionally. Now both instruments are flanking the lens. The phaco tip is sub-incisional around the lens proximally, and then the chopper is around the lens distally. Both instruments are deep at the densest part of the lens. I bring the instruments together and it cuts it in half. I turn and pronate my hand and I'm sliding with the chopper, making sure I push down a little bit, sliding under the rexus edge around the right heminucleus. I slide, make sure I get all the way to the equator, and then I pull it centrally toward the phaco tip, and I fracture the lens against the phaco tip, and that is a cross chop. And look here, I'm going to try to grab that first quadrant, but look what I'm doing. In order to prevent that vacuum that I'm trying to grab that lens piece, when I use a vacuum to grab the lens piece, I might grab the iris. So I'm using the chopper to shield the iris from the phaco tip. I'm able to pull that lens piece up and emulsify that first quadrant. Turn the second quadrant in front of me. Try to go after it with some vacuum, but you can see it didn't really want to come forward. And so what do? Don't go after it with vacuum because you might eat the iris. So don't go after lens pieces with a high vacuum in this situation. You're going to get burned. So look, see what I did there? I just placed the chopper around the lens and pull it centrally towards the phaco tip. Remember, in that central safe zone, I'm not around the iris. You want to keep that phaco tip right in that position. Go ahead and turn the second heminucleus in front of me, placing the chopper around the lens, hooking the peripheral lens, pulling it centrally toward the phaco tip, and then fracturing the lens. Crushing that quadrant in half, and then emulsifying that lens piece. Using some vacuum to grab that fourth quadrant up, just very gently. But you see I had that chopper ready in case I felt like it was going to get close to that iris edge, but it wasn't there. Grabbing that fragment again, and then crushing it into smaller pieces, and then emulsifying the lens piece. So that was the fourth quadrant. So now I'm going to remove the epinucleus, but as you're going to see here, the epinucleus is kind of stuck, almost like an epinuclear bowl within the bag. And so what should you not do? Don't go after it with high vacuum. If you go after it with high vacuum, you're probably going to grab the iris, or you might grab the posterior capsule. Your view is very limited. Never, never, never go with high vacuum to grab the epinucleus. Instead, you see I'm sliding the chopper around the epinuclear lens material, getting under the rexus edge, hooking the lens material, pulling it centrally towards the central safe zone. You can see my phaco tip is right in the middle, and I'm able to eat some of that epinucleus. I'm hooking and rotating my chopper, so I'm grabbing into the subincisional epinuclear material, bringing it up towards the central safe zone in the middle, and then using vacuum to grab the epinucleus and pulling it out of the eye. I'm keeping the chopper deep throughout this maneuver here. You can see there's some lens material in the subincisional area, but look what I'm doing. I am using the chopper to retract the subincisional iris. So no reason to use iris hooks when I have the chopper to provide localized iris retraction where I'm doing the action for the surgery. So I'm able to provide customized and localized iris retraction in the areas that I need it so that I can remove the lens pieces accordingly. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the eye and a handpiece. I always start subincisionally, removing the lens material from anterior to posterior. You can see the pupil is rather small. I'm going to use the Lester here to retract the iris as I go around. And I'm doing two things. I want to make sure that my capsular rexus is intact. I have 360 degrees of an anterior capsule, but also be able to retract the iris so I can remove any more lens material that might be hiding underneath the iris. I always start subincisionally, and you can see I switch to polish mode, polishing the posterior capsule. And once I grab a big chunk of lens material, I switch to cortex mode, remove that material, and then switch back to polish mode. I'm polishing under the rexus edge here on the left side, also retracting the iris as well to see if there's any more material, and also making sure again that the anterior capsule is intact. Doing the same thing here, contra-incisionally, going around circumferentially, polishing under the rexus edge as well to remove any lens epithelial cells, but again, just to confirm that my rexus is intact, and also to look for any more lens material that might be hiding in the capsular fornix. So using the Lester in this context is really quite helpful. I'm able to provide localized and customized retraction over the areas that I need as I'm going around circumferentially, remove any lens material, but also just checking the integrity of the capsule and making sure my rexus is intact. I'm pulsing some BSS into the subincisional capsule fornix. You can see there's a little bit of lens material there. And then I switch to cortex mode, eat some of that piece up, and switch back to polish mode. And this is very important. Before I push cohesive viscoelastic, you don't just yank the INA handpiece out. You want to decompress the chamber. Why? Because if I have high pressure and I just yank the INA handpiece out, the iris may follow out and cause iris prolapse. So you want to decompress, turn off infusion, decompress the eye, and then let the INA handpiece out, and then fill the eye with the viscoelastic. You see I'm polishing around with the sweeper as well a little bit. And you don't want too much of OVD. You don't want to have the eye overinflated with cohesive viscoelastic in this kind of situation because of the potential for iris prolapse. So I go ahead and place a single piece of acrylic lens into the capsular bag. You see I'm turning the eye away from me. I'm doing that because I can see the contralateral rexus edge, and I'm able to inject that lens underneath the rexus edge. And then with the assistance of the Lester, I'm able to retract the iris, making sure that the lens is completely within the bag. I'm tilting the optic, getting underneath the optic, removing all the viscoelastic from within the bag. Also, again, using the Lester to confirm that both haptics are in the bag as well. Remove all the viscoelastic from the anterior chamber. And then before I come out with the INA handpiece, you want to make sure you decompress the anterior chamber, make sure it's nice and soft before I pull that INA handpiece out. Again, you don't want to have high pressure, which will cause sudden iris prolapse. Go ahead and hydrate the incisions. Again, this patient had significant IFIS, which was really manifest when I was doing my rexus. When I did my rexus, you saw the pupil started to really come down, and you saw that as I was doing the rexus and I was having some OVD egress, even though I have those micro rexus forceps, there's still going to be OVD egress. And as I was having OVD egress, you can see the iris was starting to come out. I was gently decompressing as I was doing the rexus and being mindful as I'm doing the rexus to make sure I didn't get any really aggressive iris prolapse. And then, of course, during hydrodissection, because you're putting all that additional volume during hydrodissection, being very mindful of not overinflating the eye. With each wave, I stopped and then decompressed the eye, did some more hydrodissection, decompressed the eye again. Fortunately, I was able to get the lens nice and loose. And then during lens disassembly, remember, I was able to shield the pupil with the chopper as I was doing the lens disassembly. With the double chop and cross chop, because I do not use vacuum, I'm able to position the chopper and Phaco tip around the lens using mechanical fracturing forces only. And because I'm flanking the lens with the instruments, I'm able to crush the lens mechanically without any vacuum whatsoever. This is really an ideal technique in a situation where you want to avoid vacuum because the iris is so close to the action. I was able to perform cross chop, which again is the same technique, which is slightly different by placing the chopper around the lens and pulling it centrally toward the Phaco tip and fracturing the lens against the Phaco tip. All of these maneuvers are mechanical fracturing techniques, using just mechanical fracturing forces to flank the lens with the instruments and then crushing the lens without needing any vacuum whatsoever. And again, with removing of each piece, I was very careful about shielding the iris from the Phaco tip, using the chopper to retract the iris as I was eating the pieces. You saw I did that contralateral to me, also to each of the sides. And subincisionally, I also retracted the iris to be able to get any of that remaining lens material during the INA step of the case. And then at the very end, you saw I was able to retract the iris after the lens was in during IA, retracting the iris so I can make sure I clean everything up real nicely. And this patient has dementia and is a little bit unreliable with regards to his instructions, taking his drops, and I'm worried about eye rubbing. So I'm going to go ahead and place a tendonylon suture to prevent iris prolapse. So again, management of fluid, being mindful of your vacuum, keeping the Phaco tip away from the iris, using the chopper as a shield, and again, using mechanical fracturing forces so that you don't have to apply vacuum with lens disassembly. So I hope this was helpful to you, and I thank you for your attention.